45-year-old patient with a history of diabetes complicated by ESRD on HD Monday, Wednesday, Friday via left upper extremity AV fistula presents with right lower extremity cellulitis. Patient happened to bring their blood sugar log and you decide to look over it and see that the patient's blood sugars have been consistently in the 120s over the past 3 weeks. The patient's last HD session was 3 days ago, so they missed last HD because of a transportation issue. The ED vitals happen to be normal, and the admission labs are as follows. So a K of 5, creatinine of 10.4, BUN of 76, an A1c of 8.5%, and an albumin of 2.4. I discontinued the T-Billy that automatically populates out of spite. So, which of the following serum labs will be most helpful in assessing their level of blood sugar control? A repeat hemoglobin A1c, a fructosamine level, or a point of care glucose? I'll give you 20 seconds to think about this. All right, so the answer, because I'm a mean person, is actually the point of care glucose. It's not the fructosamine, but we're going to go over why later. Okay, so what's cool is there's actually a way to correlate hemoglobin A1c to blood sugar level. So the link below is actually a calculator you can use that's validated by the American Diabetes Association. And so it's kind of good to understand the trend. So here's a table that kind of correlates with this calculator. And so the higher your A1c, the higher your plasma glucose should be. But if they are discrepant, something is off. And that should make you wonder, is my hemoglobin A1c accurate or not? So once you ask yourself that question, and if you decide my A1c is not reliable, you should ask yourself, well, why is that? And so here are parameters that can falsely affect your hemoglobin A1c. So remember that a hemoglobin A1c is a percentage of glycosylated PRBCs that are glycosylated to a certain degree. So if you have low RBC turnover, your A1c is actually higher because there are old RBCs in circulation. So your overall percentage of glycosylated RBCs goes up. If you have high turnover, on the other hand, you start removing young RBCs from the circulation, and so the effect is low. In chronic kidney disease, it could be either high or low. So if you have a lot of urea, which this patient has, a BUN of 76, the A1c might actually be high. And if you're checking it during HD, you get RBC destruction as the blood passes through the filter. That can actually drop your A1c. The last thing you have to think about is if the patient got blood transfusions, then your A1c of your donor actually affects the A1c of the patient in this case, or in that case. So what about a fructosamine level? So the way I like to think about it is a point of care glucose is real-time blood sugar. Fructosamine is blood sugar average over weeks, and then an A1c is over months. So if an A1c is not reliable, generally speaking, a fructosamine is good. However, they correlate with albumin levels. So if a patient has a low albumin level, it can falsely decrease the fructosamine level. So patients who have cirrhosis, protein-losing enteropathies, or remember that albumin is a negative acute phase reactant. So if you are inflamed, your albumin goes down. So your fructosamine is actually lower. There's no fudge factor for this, so it's really not helpful. So in this patient, in the vignette, their BUN was 76. They're on HD, so their A1c is not particularly reliable, but their albumin was 2.4, and that's why you can't use a fructosamine level. That's that. So let's review all of this. So interpretation of hemoglobin A1c, I hope you like a little piece of chocolate. The first question is, does the A1c correlate with blood glucose levels? The answer is yes, you're done. You can use the A1c if you want, but you can just use the sugars. And then if it's not, you must ask yourself, what scenario am I in? Am I in a low RBC turnover scenario, high RBC turnover, chronic kidney disease, or did they get blood transfusions? Finally, a serum fructosamine level correlates with the serum albumin, so it cannot be interpreted in hypoalbuminemic states. Questions, comments, thoughts? Alrighty then. Thanks for tuning in.